Hello everyone, today we are going to talk about some rules and criteria that are probably pretty familiar to you. The Wells criteria for PE and DVT and the PERC rule-out criteria. So pulmonary emboli are scary and they're things that you don't want to miss. So it's good that we have an evidence-based tool for our decision making on how to manage patients with suspected PE. So the Wells criteria, I think, are a little bit more challenging than some of the other rules, criteria, algorithms we've talked about, because this relies a little bit on your clinical decision making and your clinical experience to use the scoring system. So let's get into it and you'll see what I mean. So clinical signs and symptoms of a DVT gets you 3 points. So does PE, being the #1 diagnosis, are equally likely. And I think this is where your clinical experience and decision making really comes into play. Do you know what the signs and symptoms of a DVT are? Do you know what a PE presents like? And do you know if your patient is likely to have one? Is this their most likely diagnosis? This is something that comes with experience. And when you don't have that experience, you should definitely rely on the residents and attendings that you're working with to show you how they think about these patients and how they're evaluating using this tool. Next up is heart rate greater than 100, a mobilization for the last 3 days or surgery in the last 4 weeks, or previously objectively diagnosed PE or DVT. Each one of these gets you 1.5 points. And these are a little bit more objective, like the rules we're used to seeing, where you can just ask a patient or check a vital sign and get the result. Next up is hemoptysis and malignancy with treatment within the past 6 months. These get you 1 point each. So you've gone in to chat with a patient, you've talked with a resident about your differential, and you're going to present this patient to your attending, and you're going to include a Wells score. But what do you do with this score, and what does it mean for the care of your patient? Well, originally when they were developing the score, they came up with this 3-tier model you see on the right. It had low, moderate, and high-risk groups for PE. The downside of this model was that you had to use different types of D-dimers depending on what you thought their pretest probability was. So if they were in the low-risk group, you had to use a moderate D-dimer. In the moderate risk group, you had to use a high-sensitivity D-dimer, and so forth. But in the 2-tier model you see on the left that was developed later, you can use a moderate sensitivity D-dimer to safely exclude PE in patients who are in this top group, the score less than or equal to 4, the PE unlikely group. So in that group, if you get a moderate sensitivity D-dimer and it's negative, you can stop the workup. If their score is greater than 4 in the PE likely group, you don't even get a D-dimer, you go straight to imaging. So the 2-tier model has a sort of really streamlined how we're thinking, and it's taken some of the guesswork out of, do I get a D-dimer, do I not? So let's say you're really against getting a D-dimer. You don't want to get a D-dimer or imaging in your patient because you think they're pretty low risk, but you still want to be confident and have evidence to support that they don't have a PE. Well, if your patient meets all of the criteria in the PERC criteria, then you can be confident that their risk of a PE is less than 2%, and they don't need a D-dimer or a CTA. So if their age is less than 50, their pulse is less than 100, their satting greater than or equal to 95%, they haven't had hemoptysis, they're not using estrogen or OCPs, they haven't had surgery or trauma, and they haven't had a prior history of VTE. This includes DVTs in the legs and PEs. And they don't have any unilateral leg swelling that would make you suspicious for a DVT. If all of these criteria are met, your patient does not require testing because their risk of PE is low. The important thing to remember about the PERC criteria is that, as Rebel EM says on the right there, it is only used in low-risk patients. That is the only area where it is applicable because you have to have low pretest probability for this to be valid. So I do want to sneak in one last set of criteria, though it might not be for PE. The Wells criteria for DVT is definitely something you should know because it gives you an evidence base to support your decision making for DVTs. Similar to the Wells criteria for PE, it does require you to know about the diagnosis of DVT, how it presents, and how likely it is in your patient. This scoring system gives 1 point to everything except the last criteria that we'll talk about when we get to it. So if you have an active cancer, if you've been immobile or had major surgery, calf swelling, if you have superficial veins present, if your entire leg is swollen, if you have localized tenderness along the deep vein system, so time to review some anatomy if you want to be able to check that point. If you have pitting edema in the symptomatic leg, if you have paralysis or recent plaster immobilization, or if you've had a previously documented DVT. All of those get you 1 point. If you think back to Virchow's triad, most of these make sense about why looking for these things would point you in the direction of maybe having a DVT, and then why some of the presentations would reflect you having a DVT. The last point, however, alternative diagnosis to DVT is more likely, which gets you -2 points, relies on your clinical judgment. So if you're like me and don't have much of that, this is a time where you can ask your residents, your teaching residents, to help you determine if that is true for your patient before you go present them to your attending. So now, what are you going to do with this score? Well, if they have -2 to 0 points, they're low risk. You can get a D-dimer here, but this brings up an interesting clinical point that was often posed to me. What are you going to do with that test? If it's positive, are you going to continue working your patient up for DVT, or would you like to stop? Because if you're not going to do anything with the test, you should not order it in the first place. In the next group, 1 to 2, the moderate risk group, if you fall into this group, you're probably getting a D-dimer. If you're in the high risk group, greater than or equal to 3, you are probably skipping the D-dimer and going straight to a diagnostic ultrasound of the affected limb. The Wells criteria for PE and the PERC rule both have level 2 evidence that say they are accurate, but they lack evidence to support an effect on patient outcomes. The Wells score for DVT has level 1 evidence, meaning it is accurate and can affect your decision-making, outcomes, and cost. There have been more recent studies that have come out about the Wells score for PE that are independently verifying the results outside of the original study population, which is what you need to move up evidence levels, so that evidence might change in the coming years. These criteria are super helpful. They come up on tests, they come up in clinical practice, they come up whenever you're being asked questions by your attending. These are things that you should be really familiar with, and there are a lot of criteria for each one, so if you don't memorize them, you should have these things calculated on any patient for which one of these diagnoses are in your differential, just in case you're asked about them. If you want to learn more about any of these scoring tools or just do a little bit deeper dive, these are the resources I used. I found them really helpful, and I think you will as well. As always, thanks for listening.